Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Helen Blair Simpson, who is a professor of psychiatry at Columbia University Medical Center and director of the Center for Obsessive Compulsive and Related Disorders. Dr. Simpson is also the director of the Anxiety Disorders Clinic at the New York State Psychiatric Institute. Her research program focuses on how to improve treatments for people with obsessive compulsive disorder so that they can live productive lives. Dr. Simpson's research is interdisciplinary and includes treatment development studies, clinical trials examining the effects of medication and cognitive behavioral therapy, brain imaging studies exploring the brain mechanisms of obsessive compulsive disorder, and animal studies in collaboration with basic scientists. Her work has been funded by the National Institute of Mental Health and private foundations like Obsessive Compulsive Foundation and the Brain and Behavior Research Foundation. Dr. Simpson was a member of the work group that developed the first practice guidelines for the treatment of patients with obsessive compulsive disorder for the American Psychiatric Association. Dr. Simpson is also an advisor to the World Health Organization for obsessive compulsive disorder and related disorders. Dr. Simpson, welcome to The Therapy Show.
Thank you so much for inviting me.
So can you start by telling us a little bit about your personal background and professional development that led to your research in the field of obsessive compulsive disorders, which is more commonly referred to as OCD?
I'm happy to. So I never knew that this is what I'd end up doing, but I was born and raised in Massachusetts, and I went to college at Yale College and majored in biology. And what I loved as a kid and through college was animal behavior. So I actually did a lot of animal behavior research. So I studied frogs and I studied squirrels. But I come from a family where public service is really sort of the top value. And that means helping people. And I didn't see quite how animal behavior research would fit that other value and need of mine. So that's what got me to do what's called an MD PhD program. So you go get training to become a doctor, and at the same time you get scientific training. And I got a PhD in neuroscience, and I did that at Rockefeller University in Cornell. And my PhD was, I studied the brain circuits underlying vocalizations in songbirds. You still see my animal behavior interest. But then I had this challenge at the end of that program. How do I put the two sides of myself back together again? Which is, on the one hand, I like animal behavior. And on the other hand, I'm now a doctor and want to help people. And my solution to that was to pursue psychiatry training, because psychiatry is really the study of behavior, although it's the study of abnormal behavior. But I thought if you can figure out why people's behavior went awry and develop new treatments for them, well, then you could help them. So that brought me to Columbia University, where I did my psychiatric residency training. It's one of the premier training departments in the country and also has a very large research portfolio. And I got really interested in anxiety and OCD. So I did fellowship training in that, got onto the faculty and developed a research program. And I'm now a full professor and the vice chair for research. And I have been doing research on OCD with funding from the National Institute of Mental Health since about 1999, and I work with a fabulous research team, and we feel really grateful and fortunate to be able to do this work.
So how would you briefly explain OCD to a non-professional?
Well, I'd say it's a terrible disorder. It can be a terrible disorder, and it can be very disabling. And the key features of it in some ways are very simple. People with OCD have obsessions, which are intrusive thoughts, images, or urges or impulses that come into their head that they find very distressing and concerning. And they have compulsions, which are repetitive behaviors, either, in the world or in their head that they do over and over again. Usually they feel driven to perform them. They may not know why, but they feel like they have to do them. And the important thing is we can all have an occasional intrusive thought. Oh, gee, do I have my passport? You're going to the airport and going overseas and you double check. Oh my gosh, do I have my passport? There's an intrusive thought. Or you might have a checking behavior. Did I lock my door? And you check more than once. That isn't OCD. That's just sort of the way the brain works. OCD is when you have obsessions and compulsions that are highly distressing, that are time consuming. A yardstick would be more than an hour a day, but we work with patients who are obsessing, compulsing, 3, 5, 8 hours a day or all day long. And that, importantly, the symptoms really impair their functioning in their lives.
Are there different types of OCD?
Well, OCD has that structure, but the content of obsessions and compulsions can really differ. So, for example, one person with OCD can be really worried about contamination and have a lot of washing rituals. Another person could be very concerned about intrusive thoughts about harm, either to themselves or to someone else, and they're doing a lot of checking rituals. Yet another person could be really concerned about symmetry and organization and ordering all day long. And then there's another sort of common content that is OCD, which is having taboo thoughts, such as violent or sexual images against people who you really don't want to be having violent or sexual images about. And it's not like people fall into one of these categories. People can have a mix of content. So the content of people's obsessions and compulsions can differ. It's also true that people can have different emotional experiences. A lot of people with OCD have a lot of anxiety. They can even have panic attacks if they're triggered by their OCD trigger. Others can have more of an emotional experience of disgust. Still others can have just a sensation of it doesn't feel right. So again, in a simple way, everyone with OCD has obsessions and compulsions, and there's sort of a real stereotypy to that or consistency to that. But why one OCD patient can seem so different than another OCD patient is both in the content and the emotional experiences, and then also in what other disorders they have in addition.
So why is it important that therapists who are treating individuals with OCD have formal training in this complex disorder before they work in the field?
Well, my position as a mental health provider is I wish all of our mental health providers were formally trained and really expert in what they do. And my perspective on this is we don't want to send a patient to a surgeon who doesn't know how to do the surgery. My gosh, why would we send someone to a therapist who can really change a patient's life or not, and who can also change their brain or not? Why would we send them to a mental health therapist who wasn't really highly trained as well? So that's my basic position, is that mental health should not be treated with any less respect than our other medical illnesses. But in the case of OCD, it's also true that because the illness can have so many different sort of ways it presents, and because the treatment to be effective needs to be done in a very specific way, it's really important for a therapist to be really trained in how to treat OCD, because it isn't like one OCD patient looks identical to the next one. It's not sort of simple in that way. The other thing that's important is that, particularly with the therapy, well, it's also true with the medication. You want someone who really knows how to help someone get on medication and get to the right dose. But likewise for the therapist, you want someone who really knows how to do the cognitive behavioral therapy that we know is so effective the right way. Because if they do it the wrong way, either giving medications or the cognitive behavioral therapy, then patients can drop out of treatment, and then they can have the wrong impression that this doesn't work.
So why is early intervention so critical when treating OCD?
So early intervention, I believe, is critical for treating most of our psychiatric disorders. You know, there's been some really interesting work in early intervention for psychosis that has shown better outcomes if you get to people who are in their first episode of psychosis earlier rather than later. We don't have all of that data for OCD, but we have some hints that the same is true for OCD. So my clinic, we work with people who are 18 and above, and we often see people in their 30s and 40s who have OCD. And even if we can treat them then and get their symptoms completely to minimal, under control, we can't give them back their life, right? So we can't give them back the stuff they didn't learn in high school or the friends they didn't make in high school because they were suffering with OCD. We can't give them back that they can sort of finish college and graduate and get a good job. And some of these people may not have dated ever because of their OCD, for example, if they have terrible contamination concerns. So it's not just the symptoms that one has to treat. If you have those symptoms early so half cases of OCD in epidemiological studies start by age 19, a quarter of them start by age 14. So if you think about that, if you have all this OCD all through adolescence, how does that get you off your developmental track? So that would be one argument I would make for earlier intervention, which is how do we help people with their symptoms much earlier so that they can actually go through life's trajectory like the rest of us and learn all the other things they need to learn in life to get to where they need to be in their 30s and 40s. But the other thing is there starting to be hints about how the longer you have OCD, how it can change the brain. And again, even though we don't have all the hard data yet, I propose, or my hypothesis would be, once we start changing the brain, that's when it can become harder to get good treatment outcomes. So for both those reasons, both because of the suffering and because of the potential better outcome from treatment, that's why I believe early intervention is really important for OCD.
So since parents are the best experts on their children, how can a parent recognize if their child has OCD symptoms?
My recommendation to parents would be look for anxiety, because that's pretty easy to see. It may not be differentiated yet. You don't know what your child is anxious about, but look for anxiety. And even if it isn't OCD, you want to get the anxiety treated too. And also look for avoidance. So when you start seeing your kid avoiding situations that you see other kids really going for and being excited by, and you're wondering, why is my kid doing that? That can be another clue that anxiety and possibly OCD is at work. You also want to observe your kid in terms of what's triggering that anxiety or avoidance. And if you see some of the typical domains that I described above, triggering that, that's something. And then finally, you can actually observe compulsions. Now, you can observe the compulsions that people do in their head. We call them mental rituals, and they're very common in OCD patients. But you can observe excessive washing, excessive checking, excessive ordering and arranging. And usually those are things that cause kids not to be able to move forward. They get stuck in doing things over and over again. And finally, obviously, if your kid isn't functioning in school or with their peer group, that's obviously a time when we parents really want to sort of ask ourselves, what's going on that I don't know about? How can I talk to my kid? How can I help my kid figure this out and get the right treatment?
Can you explain the interdisciplinary approach that you developed to treat OCD?
I'm happy to do so. And I want to just sort of point out, it's not just me who's developed this. There's been a whole body of research over the since the 1980s, 1970s about how to treat OCD. And what we know from all of that work, including my own, is that there are two treatments that work for OCD. One is pharmacotherapy with a class of medications called serotonin reuptake inhibitors. And this includes the tricyclic antidepressant called clobipramine, but it also includes the selective serotonin reuptake inhibitors. And these are medications that are fluoxetine, paroxetine, sertraline, citalopram, probably names that people are familiar with. Those are the generic names, not the trade names. The trade names would be Prozac, for example. So those medications work. We know that from in both adults and children, and we know that from randomized controlled trials, which are the gold standard of how we figure that out. The other treatment that we have that we also know that works is a very specific type of cognitive behavioral therapy called exposure and response prevention, or sometimes called exposure and ritual prevention. And we also know that that therapy works from many, many different randomized controlled trials. Where I come into this picture is many years ago, two mentors of mine, Dr. Edna Foe at the University of Pennsylvania and Dr. Michael Leibowitz here at Columbia, partnered to do a study that was funded by the National Institute of Mental Health to compare cognitive behavioral therapy to medication or their combination in a group of adults with OCD. I had the incredible fortune to be both a psychiatrist at first on the study, and then I was a therapist on the study, and trained by a wonderful man named Michael Kozak, who unfortunately has since died, but who really made wonderful contributions to the field. He was a fabulous supervisor. So what that first randomized controlled trial showed was that both the cognitive behavioral therapy and the SRI medication were superior to a pill placebo, but that the therapy, with or without the medication, was superior to the medication alone. So these were really interesting findings for the field that showed really the power of cognitive behavioral therapy. But there are a couple caveats, because these were highly trained therapists in patients with OCD who didn't have a lot of other comorbid disorders. But it did show that if you really do the treatment in a correct way with a highly trained therapist, you could have very powerful effects. But what we knew back then, and it's sort of still true today. Most patients don't have access to that therapy. So most patients with OCD today, particularly adults, their first line treatment is the medication. And what the medication alone showed was it definitely was better than pill placebo. But in fact, people still had a lot of symptoms at the end of the trial. Even people who responded still had symptoms. And that's the typical case, not just with the medication we studied in that one study, but with all the SRI medications, is that they can reduce the symptoms, but it's in less than a quarter of people will they take the symptoms completely away. So the second study we did addressed that question, which is, okay, what happens now if you recruit people with OCD who are already on a medication, but they still have symptoms, which, as I said, will be the majority of the people. They've been on a great dose of the medication. They've been on it long enough, which is typically 10 to 12 weeks, but they still have clinically significant symptoms of OCD. What happens if you add the cognitive behavioral therapy then? So we did 2 studies where we compared exposure and response prevention to a different cognitive behavioral therapy, stress management. And we did a second study where we compared exposure and response prevention to adding a medication called risperidone, which is an antipsychotic, which is typically what psychiatrists do because it's a medication that's been shown to be effective when added on top of an SRI. And both of those studies, done 5 years apart, completely different therapists, completely different samples of patients, showed the same thing, which is in adults who are on a serotonin reuptake inhibitor who still have symptoms, the best thing to do is to then add exposure and response prevention that you can get, another 40% of people well. That's really, really important, right? Which is, so what I say to people now is you can start with medication if that's what patients prefer. You can start with the cognitive behavioral therapy, focusing on exposure and response prevention. Both of those are perfectly reasonable and good places to start. But if the medication isn't enough, add the therapy to the medication. And obviously the studies we don't have is if the therapy isn't enough. Would I add the medication? Sure, I'd try it. Now we're just finishing up the 4th study in this series, which is many of our patients, they've been on that medication. They still had symptoms. They then get the cognitive behavioral therapy using exposure and response prevention, and they get well. And I mean minimal symptoms at the end of that course of treatment. The most common thing they ask when they become well is, hey, doc, can I go off my medication? And the reason why is because the medications, even though they're typically very well tolerated, they still can cause weight gain. They can cause sexual dysfunction. And most of us don't like having to take a pill every day for the rest of our life. So that's the study we just finished now, and we're just looking at the data. Now, obviously, there's the other half, which is, well, what about the people who they've been on that serotonin reuptake inhibitor medication? They've also gotten the cognitive behavioral therapy. They've done both, and they still have symptoms. That's obviously one of the places where we're doing a lot of active research. How do you help those people where our first line treatments alone or together still are not enough?
Are there any findings? Are there any clues?
There are a lot of clues. And this is really where funding for research becomes really, really important. So what we know is that there have been a handful of small randomized controlled trials of adding antipsychotic medications like risperidone. The important information about that is that only helps at best a third of OCD patients. So it's something that's tried a lot. It's just fine that it's tried. But one of the things that I often say to clinicians is if you try adding an antipsychotic and it doesn't help the person you're treating, I beg people, please take your patient off that medication, because if you don't, then you actually leave them on a medication often for a long time, because other people won't necessarily take them off that medication, and you'll be giving them a medication that has pretty significant side effects, particularly over time, no benefit. There are a lot of other things that we try, but they haven't been as well studied in randomized controlled trials. They've been studied in either small randomized controlled trials or open trials. And they really need a lot more work. So sometimes, for example, we try adding stimulants on top of a serotonin reuptake inhibitor medication. That sometimes can be helpful for people. There's also a lot of research in this area. So for example, people have gotten very excited by a class of medications called glutamate modulators. These are things like minocycline and memantine, and we've also studied things like ketamine. it needs a lot more research to sort of know what to do there. In my clinic, where someone on my team now is really interested in the endocannabinoid system, and we're looking to see whether different cannabinoids might be helpful in the treatment of OCD. There's a lot of work going on right now in the field on what's called neuromodulation, and particularly non-invasive neuromodulation, using magnets, for example, to try to alter circuit function to help OCD symptoms. And in fact, a particular type of neuromodulation called deep transcranial magnetic stimulation was just approved by the Food and Drug Administration for the treatment of OCD in people who had failed first-line treatment. So there's a lot of interest and research in the field. I would argue that what really gets in the way is research funding, because these are studies that are expensive to do. A lot of times you'll get negative findings. And so the question is how can we get the research funding from foundations or philanthropy or the National Institutes of Mental Health to move quickly through new treatment options to try to bring new treatments to our patients?
I agree, especially with OCD because it's so debilitating.
That's right.
What would you tell someone who is concerned about taking medication and just wants to start only with CBT?
Starting only with CBT is an absolutely fine option. As I told you about our first study, in fact, the CBT consisting of exposure and response prevention performed by highly skilled therapists with patients who adhered to the treatment, in fact, was superior to medication alone. So I'm a big fan of people who want to start with CBT because it does two things. Not only can it actually really help with the symptoms, but what I find is that people who've had OCD for many years can really feel terrible about themselves and feel sort of not in master of themselves. And one of the really great things about that treatment is you teach people to be their own therapist. The goal isn't that they come here to my office and do CBT with me in the office. The goal is that I'm teaching them the skills so when they're outside in the world, they know how to handle themselves, their OCD when it comes. And that means exposing themselves to what they fear while not doing their rituals and allowing themselves to learn that the terrible fear that they have doesn't happen. So I'm a big fan of CBT because it can give people back a sense of mastery over their OCD, and that they're a person with OCD. It's not that they're just OCD. Now, having said that, we've done, my team here, Sapana Patel, worked with us to do studies on treatment preferences by patients with OCD. And we know that our OCD patients have really strong treatment preferences. So some people want to do CBT and they don't want to consider medication. In fact, there are other people who don't want to do CBT because it's tough, it's hard, it's a lot of work, and it can be really frightening at first to expose yourself to the things you're fearful of. They'd much rather start with medication. Our experience is that some of those people, when they start with medication and they do get better with the medication, but they don't get well enough, that's another moment to start having the conversation with them about, okay, what can we do next? And then it's a conversation about, what would you rather? Now try the cognitive behavioral therapy now that your symptoms are a little lower and you might better imagine being able to do it? Or do you want to try this antipsychotic medication with all its potential side effects? And so I find it becomes another opportunity to help people reconsider. And I believe that until people have had really good trials of both the medication and the CBT, they are not treatment resistant. They are not treatment refractory. They haven't had both treatments that work.
And the important caveat there is that they are seeing an actual trained CBT therapist. When you're thinking of starting with CBT, make sure they're trained. Is that correct?
Absolutely. So it's a very specific treatment. You want to make sure not only that the therapist is doing it correctly, but the other really important part is that the patient is adhering to the therapy. So one of the most powerful predictors of outcomes to the CBT that we found in study after study is patient adherence. So if the patient is really doing the exposures with the therapist and refraining from their rituals, and they're really practicing it and doing it on their own on the outside, those are the people that are going to get the best results. This is a very focused, skill-based treatment. It's like learning a new language. It's like learning Spanish. If you just come to class and listen to the teacher, you're not going to become fluent in Spanish. It's much more about making sure you go out in the world and practice that language with everyone you can, and even go to Spain, or South America to really perfect the tongue. That's the model for what CBT really should be.
Do people suffering with OCD have a higher rate of suicide?
This is an interesting question, and there isn't super great data on this. It used to be thought that suicide risk was relatively low, but in fact, more recent data suggests that suicidal thoughts occur at some point in as many as about half of individuals with OCD, and that suicide attempts are also reported in about a quarter of individuals with OCD. And yet the presence of depression and severity of depression and anxiety definitely increases the suicide risk. So I obviously always evaluate my patients for suicidality, and in the setting of when they have other anxiety or comorbid depression, it's something I pay very close attention to. But it's also true I have many OCD patients who are not suicidal at all. So it's really about an individual evaluation that needs to happen. But certainly people can get really demoralized by their OCD and can really start to feel like life isn't worth living. It doesn't mean that they necessarily are going to kill themselves, but they can feel like there's no point in living because their life is such torture. That's the nature of OCD. It's really a very mean illness. It often invades the exact things that people value most. And it gets all involved and inside these things that people value most.
So what's the average length of treatment for somebody working with this integrative protocol?
So we usually recommend for medications is a trial of about 10 to 12 weeks of a serotonin reuptake inhibitor. And so typically my goal is to start at a low dose to minimize side effects, to get people on then a good dose. And for OCD, we typically go to the high end of the range. The data suggests that higher doses, you'll get better effects. And then once you get someone to that high dose in the range, you really wait. You let that medication have enough time, another 6 weeks before you decide what that medication can do. I tell people you're going to get all the side effects up first, and the benefits typically what it does is it just sort of slowly accrues over time. So people at 4 weeks or 6 weeks can say to me, "Oh, gee, doc, I don't know if this is doing anything to me." And I say, let's give it a little more time. And by another 4 to 6 weeks, they can usually see an impact. But remember, you have to set expectations, right? Which is typically for most people, it's not that their symptoms go completely away. It's just that their symptoms are reduced. So I like to tell people what we're looking for is the glass is now half empty, not that the glass is still half full. If that makes sense. So medications, it's usually sort of a 12-week trial, something like that, to see if that medication works. The cognitive behavioral therapy, how we deliver it in the clinic and how we delivered it in those clinical trials, we would do 17 sessions. We've done it different ways. The very first study, we did it 5 days a week for 3 weeks, 2 home visits. Everything was done in a month. And that was the intensive version that was originally developed by Edna Foa and Michael Kozak. And it's a really interesting treatment to do because it's so intensive and you can have dramatic changes in people's lives in a month. I mean, it's really a fantastic treatment to do it that way. The problem is that's really difficult on therapists and it can be really difficult for people. And most insurance companies don't reimburse that type of level of treatment. So the next studies we did it twice weekly over 8 weeks and got very similar comparable results. So that's our typical protocol is about 12 weeks for the medication. And typically if a person can come twice weekly, we can get the 17 sessions done in about 8 weeks. Now, this is a little teaser, which is the new study that we just finished. One of the things that we're finding is that for people who aren't well by the end of that 8-week or 17 session treatment, offering just up to 8 more sessions can help a lot more people become well. So this is something that typically happens in clinical practice, which is, someone isn't well yet, so you want to give them some more. Our data suggests that that's a really good thing to do. Whether going past 25 sessions is helpful is a different question. We don't have good data on that. But I guess my overall point is for such a bad illness, what was amazing for me to see as a psychiatrist when I first worked in these studies is that you could make such a difference in people's lives in 3 months. If you had trained therapists and really good psychiatrists and the medications were working and the therapy was working and the patient was doing it, you could see dramatic change in 3 months. I think that's really good news. And I think it's a really important thing for patients and families to know. Yes, There are many people who will continue in treatment, continue on medication, continue to have some maintenance treatments. But when the therapies really work, they really work, and they work quickly.
What are the most common obstacles that prevent patients from seeing the full benefits of OCD treatment?
Well, one obviously that we see a lot is clinicians miss the diagnosis, and so they don't even start the treatment. They might not even detect it in the first place, or when they detect it, they misdiagnose it. So that's a problem right off the bat, right? Then the second one we see a lot, because we're an expert clinic, so we see these cases, right, is clinicians put patients on serotonin reuptake inhibitors, but they never push the dose. So someone might be walking around, for example, on 20 milligrams of Prozac for 5 years, and no one ever thought to say, well, gee, why don't we go to 40 milligrams or 60 milligrams or even 80 milligrams? And sometimes when people like that come to us and we just push the dose, they get the benefit they need and they don't need more treatment. Likewise, over on the cognitive behavioral therapy side, the most common thing that we see is people say, oh yeah, I got cognitive behavioral therapy for OCD and it didn't work. But either they didn't get exposure and response prevention, they got cognitive therapy, they might have gotten supportive therapy, some people have even gotten dynamic therapy, but they didn't get exposure and response prevention. Or the way that exposure and response prevention was delivered was not ideal. So for example, the therapist didn't actually do exposures with the patient in the session. Or third, the patient didn't do any homework. So it's once again, it's a therapy that, it can't work without the homework. So I think those. Now, having said it, and I don't want to be a Pollyanna about this at all. Look, I'm a big supporter of first-line treatments for OCD and early intervention and detection and diagnosis. And it's also true, and it's tragic. I would say with those treatments, about half of people we see, we can get well. But the other half are doing their best, have tried their best, and they're not yet well. And we don't know why. And I believe that at the end of the day, when we know that, it's going to be something about their illness or the particular brain circuits that are connected to their illness. And our treatments are not helping them because what our treatments are doing aren't helping those individuals with what's wrong in their brain that's leading to their symptoms. Does that make sense?
Absolutely.
So I can tell you that it's when I first, a number of years ago, Dr. Moira Rin was here, and we partnered together to do some studies in children and adolescents. And my naive notion at that time was, children and adolescents will look like my adults, because I'm not a child psychiatrist. I hadn't seen a lot of that. And certainly some of them do, but I was really unprepared for the seriousness of some of the child cases that I saw of kids who were 13, 14, 15, who their families had been through, it was just purgatory, right? Which is their kid had been sick since the kid was 6, 7, or 8. They had tried everything possible that we know of to try, and the kid was still horribly ill, and the families were terribly suffering. So that's also, unfortunately, an aspect of OCD, and I also see it in our OCD patients. That's the reason for research. That's why my team is focused on research, which is, again, one part of it is making sure the treatments we know really work get out there, and that's really important work, access. But the other one is, why doesn't everybody benefit from our treatment? And it's not just because the clinician didn't know what to do, or the therapist didn't know what to do, or the patient didn't hear. Sometimes everything has been done as best as it can be, and the person's still suffering.
Can you share any poignant examples of where this integrative approach had a major impact in someone's life?
I'm happy to do so. Obviously, with details change, so I protect people.
No identifiers.
So I remember a man coming to me in his 30s, and he had OCD since he was 12 years old, and it hadn't been recognized until he was somewhere in his 20s. And that was when he was in school and he had terrible intrusive thoughts and had to sort of drop out of school and really became completely tortured. And his thoughts were around religion, and his thoughts were so awful that he couldn't go anywhere in the world, because everywhere in the world, there are religious symbols, right? Everywhere you drive by churches on the way to work. There are synagogues everywhere. Not to go through too many details, because again, I want to protect patient confidentiality, but this is a person who, with medication and with exposure and response prevention, and it was a It was a very intensive treatment, but he really took to it. He did everything that I asked him to do. And it was really an extraordinary journey. And he was really open to help. And, it was really meaningful to me because about a year after treatment, he sent me a Christmas card with all sorts of religious sort of signatures on it and wrote to me that it was the first time he could actually ever enjoy this time of the year. So there's an example of a transformed life. And again, it doesn't mean that someone never has a moment of relapse or never, has a problem again. But that's the sort of transformative effect that really good treatment early enough in life so that one can actually have the life one wants to lead can really happen.
That's an incredible story, really. So what are you most excited about in mental health treatment today as it relates to OCD research?
So I'm really excited by three things. So it's a great moment, actually, and I'm not like, oh, everything's great sort of person. You can ask anyone on my team. I'm always sort of the person who's like, will this work out, and being a little skeptical. And I have high standards. I don't want to promise stuff for my patients or to my families that we can't deliver. But I'm actually really excited at this point in time. And I think it's actually a moment where we can really make great progress. So for three reasons. So one is, we know that medications at cognitive behavioral therapy can help a lot of people, and we know that most people don't get it. And the problem is how do you solve that problem? Well, I actually believe that technology is going to help us solve that problem and help us really increase how to detect OCD, as well as potentially give us a tool for how to deliver high quality cognitive behavioral therapy through the internet or in combination with mobile apps. And I don't mean like, here's this program, go online. I mean programs such as what they developed in Sweden at the Karolinska Institute, where there's internet CBT programs for OCD with a therapist actually working through the platform. And it's an integrated platform where the person who's being treated actually is interacting with the therapist through that platform. I was really excited by that program. We brought it to New York. Sapana Patel translated it from the Swedish. We did a pilot study. It showed promising results. And now we're hoping to actually study that in a larger study. It's a grant right now that's in front of the National Institute for Mental Health. And we're very hopeful that if we get funded, we could actually test that out in New York and see whether could that type of technology assisted treatment be one way to really dramatically increase access to CBT for New Yorkers, because it's a treatment that one can deliver remotely. And in addition, we're actually partnering with New York State, the Office of Mental Health, to develop online trainings for frontline clinicians in how to detect, diagnose, and what are evidence-based treatments for OCD. And again, this would have been much harder 10 years ago, but the state has an online learning management platform that clinicians in New York State can access. So as we're developing these online trainings and an online toolkit, we now have the opportunity to actually train. Sitting at the New York State Psychiatric Institute here in Upper Manhattan has the potential to be able to train frontline clinicians everywhere in New York State. So I find that really exciting. And it would be the real sort of outcome of all this work that I've done with Dr. Edna Foa on the power of CBT. The power of CBT is nothing if people can't access it. The other thing that early detection through technology might enable us to do is really start looking at early intervention, because you can't intervene early if the cases aren't detected. So, again, and I want to be clear, I'm not talking about, I don't think that a mobile app all by itself is going to actually solve the problem of OCD. OCD is a much more challenging illness than that. But what a mobile app can do potentially is extend, for example, an expert therapist, so that the expert therapist can actually use the mobile app to assist them in the delivery of the treatment, so that the limited number of skilled therapists that are currently trained in the United States can have greater reach. So that's how I see those internet and mobile app platforms potentially helping. The second thing I'm really excited by in the field is really a change in scientific collaboration. And I'm very excited on that on two fronts, both on the neuroimaging front and on the genetics front. So what we know is that sometimes the way to make really fast progress in science is not for individual people to be doing things in their individual lab, but for experts to really join together and to share methodology and to share ideas, and then to be able to do collaborative studies that recruit large samples of people very quickly so we can get answers to questions much more rapidly. And an example of this is in the neuroimaging world is a consortium called the Enigma OCD Consortium that's led by Dr. Odile van de Heuvel and Dan Stein. And they have gathered, I can't remember, it's over 30 sites by now to share neuroimaging data that we've already collected to be able to actually look at very large samples of OCD patients, both adults and children. And I have a grant from the National Institutes of Mental Health, which is to collect new data with 5 of those sites. And we have developed harmonized methods for doing clinical phenotyping and neurocognitive testing and neuroimaging. And again, we're sharing ideas, we're sharing methods, and the whole goal is to sort of move science instead of this local focus to a more global focus. That's a study, by the way, that we are currently recruited. So if you have anybody listening who has OCD, who's not on medication, who'd love to participate, I really hope they give us a call. And more importantly, we're also recruiting siblings of people with OCD into that study. And we really need siblings because we want to look at not just people with OCD and healthy controls, but we want to look at siblings who share some genetic architecture with their OCD siblings, but don't have OCD. And that provides potentially an opportunity to look at both risk and resilience. So scientific collaboration in imaging, but then also scientific collaboration in genetics. So for many, many years, genetic studies in OCD, they sort of weren't finding stuff and they weren't finding stuff, or they were finding this, but it wasn't replicated. But now there seems to be real collaboration across genetic groups to share samples. And once we get large enough numbers of the genetic samples, I believe that we're going to start to identify genes that actually link to OCD. And with that better understanding of the brain circuitry and the abnormalities that are associated both with risk for OCD as well as duration of OCD or having the illness and genetics, we potentially we open up new understandings about what causes OCD that leads to new targets for treatment. And that opens up this possibility of what's the sort of buzz in the field of this thing called precision psychiatry, right? Which is identifying treatments for individuals that are really oriented towards them and their biology. So that's the second thing. And again, I don't think that's next year. I think over the next 5 to 10 years, I think we're going to see, I hope in my lifetime, we're going to see really a change there. And frankly, that's true across the field of psychiatry. And it would be enormously exciting to move from phenomenology to mechanism in OCD. And just to say, mechanism includes the environment and trauma. It doesn't exclude that at all. And then the third thing that I'm excited by is after sort of a dearth of new compounds that might be of interest or new treatments in OCD, there was sort of a period of time where there didn't seem to be anything new. Suddenly that's changing again. And so pharmaceutical companies have new compounds that they're starting to be interested in testing in OCD. I already mentioned that someone on my team is really interested in the endocannabinoid system and looking at cannabinoids as possible treatment mechanisms. There are new glutamate modulators that are coming out. And there's a lot of excitement about neuromodulation treatments, and particularly non-invasive neuromodulation treatments, such as transcranial direct current stimulation or transcranial magnetic stimulation. And I already mentioned that the FDA recently has approved something called deep transcranial magnetic stimulation for the treatment of OCD. So I actually think all 3 of those things, I'm really excited to see what happens over the next 5 to 10 years. But it really comes down to funding. And it really comes down to funding priorities. And historically, OCD, I would argue, has been underfunded relative to some of our other major psychiatric illnesses. It's really important for families and people with OCD to make sure that they are advocating for funding coming to focus on OCD. The autism community has done a spectacular job of generating attention and funding to autism. Boy, I'd love to see the OCD field do the same.
I completely agree. So if you had a magic wand and could improve one thing about mental health treatment, what would that be? Sounds like funding.
Well, obviously funding for research, but I actually would put on that list access to evidence-based care. I would love it if every American with OCD had early access to evidence-based care, treatments that we know work right now, and they could access it. And that's not true in our country. That is true, interestingly enough, in some other countries, right? So Norway's making great progress on that. England is making great progress on that. Look, why can't America make great progress on that? So I'm not yet ready to take on the United States, but we're working with New York State and the Office of Mental Health to see if we could actually change that in New York State and for New Yorkers. So access I put on that list. And then the second one is really understand what causes OCD, because the hope there is not just early intervention, but actually prevention. And when I say causes, I mean two things, right? One is, well, in the end of the day, obsessions, compulsions, anxiety, it's the brain causing that because the brain underlies all our behavior. So if you have abnormal behavior, well, then there's something in your brain that must be abnormal. And so that's sort of pathophysiology. But that's a completely different question than how'd your brain develop that abnormality in the first place? And that's etiology. And at the end of the day, as my bet would be that the etiology of OCD is going to look like the etiology of other medical illnesses, right? That some is going to be a really bad gene. Some might be development. Some might be the environment. Some might be infectious illness. It's going to be a panoply of factors that actually can trigger this and someone at risk, genetic risk. A panoply of factors that actually are why this one individual along the course of their trajectory of development developed OCD or have all those risk factors, but didn't. And that's why we're so interested in studying siblings of people with OCD as well as people with OCD.
So how can my audience learn more about your work, either online or in print?
The best thing is to go to our website. So it's www.columbia-ocd.org. And you're going to see there pictures of the team and information about us. You're going to see a list of all of our current research studies. And once again, if you'd love to participate with us, please call us. We cannot move the field forward without people in the field coming and working with us. And that includes healthy people who might have a friend with OCD and want to move the field forward, as well as brothers or sisters of people with OCD who call up their brother and sister and say, come on, let's do this together. It's also true that on that website, there's a link to current publications. So we write a lot of geeky science papers, and I don't know how interesting that will be to people, but you'll see them up there. But we also write review papers and give talks that are more for the lay people, and a lot of that is posted on our website.
And that website will be in my show notes and on therapyshow.com under the page dedicated to your work. So Dr. Simpson, on behalf of myself, my listeners, and all of the people that you've helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of OCD.
Well, thank you so much, Bridget, and it's Dr. Bridget Nash for helping me get this message out there. And I'm so happy to partner with you and the great public service work that you're doing in helping the public understand better these illnesses. And most importantly, know there are treatments. So if you're out there and you're suffering or you know someone who's suffering from OCD, there are treatments. Bring your loved one to treatment.
So be sure to check out my website, therapyshow.com, which has many resources about mental health. And there you will find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I could interview and how I can improve the show. So I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and people around the world can gain more benefit from therapy. There's no need to suffer in silence. Get the help that you need to create the life that you want.